try. Okay. So I'm going to try sharing my screen to see if it actually works.
Okay. Hello, everyone. I see you starting to log in. Feel free to show yourself on camera or not, whatever feels convenient for you. And Dr. Raman, Toor, and I are just chatting as we're waiting for people to log on. And if you don't mind putting your name and your organization and your role, and maybe something about your interest in this presentation. I'm so appreciative to Dr. Toor to present on teaching integrated care and to talk about the program that they have at University of Washington. And actually, I met Dr. Toor a few years ago. I'm in Little Rock, Arkansas. I'm a psychiatrist, and she spoke as part of the APA grant on teaching psychiatrists. And so she was a speaker for the Arkansas Psychiatry Society, Psychiatric Society, actually annual meeting, and did a really good presentation on the impact model and collaborative care management. And so we didn't even know that we had known each other when we reconnected around these questions about education. And she said, yeah, I've been to Arkansas. So welcome, Dr. Toor, for coming back for this conversation with me and with our group. This CFHA, Collaborative Family Healthcare Association Psychiatric Special Interest Group. CFHA is a multidisciplinary organization that is working hard to promote integrated behavioral health. And one of the really great things about the organization is that it is a group of people from all sorts of disciplines and specialties, backgrounds, and locations of practice. So we have social workers, marriage and family therapists, psychologists, trainees of various types. And we would like to get more physicians, psychiatrists, nurse practitioners, physicians assistants, and any sort of people who are prescribers, but also people who are involved in therapy and integrated care of different models. And there have been people working in adult settings as well as pediatric settings. So CFHA has been very generous to let us have a wide range of presenters for this meeting, and we meet every month on the first Tuesday from 12 to 1 Central Time. So Raman, if you don't mind starting off, just telling the group a little bit about yourself and your interest in this, and then just go from there.
Sure, sounds great. Thank you so much for the introduction, Dr. Gibson, and thank you for letting me know what is this group about. And I've actually heard a few presentations from past, and they're really good, very good education introduction, good discussions. So thank you for inviting me. So a little bit about myself. I'm a CL psychiatrist by training, and I learned about integrated care in my fellowship, actually in my residency. When I started a few co-located clinics to get a better access to mental health for patients in primary care. So that's when I said I need a better solution because schedule was getting full, and I didn't feel I made much of a change by starting 2-3 clinics. And that's when in fellowship I learned more about collaborative care model, specifically in integrated care. And I did fellowship at Cambridge Health Alliance, and I worked with Dr. Wong there, who actually was implementing collaborative care models in primary care. So that's how I got into this and moved here in UW, University of Washington in Seattle, 7 years ago, and I've been doing this work since then. Yeah, so thank you, and I'm excited to talk about what programs we have and a little bit about introduction about what do we do in those programs. I know we are around 8 or 9 people, so feel free to interrupt me if something specific is more of an interest, because I added all the programs I'm part of. but it might not be of interest to everyone. So just stop me. We can talk more about specific things. Do we have any kind of background on anyone? So, okay, so we're still waiting for people to sign in.
If you'd like to take a couple of minutes, if people would just unmute yourself and just say what you're interested, what your role is and what your interest is, and that'll help Raman guide her comments. Sometimes
Yes.
it's hard to speak to just a lot of names. So if you don't mind just unmuting and say what your interest is today. Thank you.
I'll start. I'm jumping in and I might not be able to stay the whole time, but I'm Monica Downey. I'm a director at Iora Primary Care, where I was looking for different ways to teach our providers and our clinicians and help them understand what we do. So that's sort of what I'm looking for. Thank you.
Hi, I'm Michelle. I'm a behavioral health specialist at Iora Primary Care and here for the same reason.
Thank you, Michelle.
Hi, my name is Jacqueline O'Dour. I'm a BHC for resident training clinic at Einstein Hospital in Philadelphia. I'm hoping to learn how to manage up and train residents in this model.
Thank you, Jacqueline.
Hi, Mary Langley. I think you heard me chewing before because I had my camera off and my mic on, so I apologize for that. I'm eating lunch, so I'll turn my camera back off after I speak. But I'm a psychiatrist and section chief for the VA, Jesse Brown VA in Chicago, and I also started in women's health and certainly had to find ways to make sure that we served our entire women's health population with one psychiatrist. So I have a sort of a casual interest in the topic, but very robust nevertheless. Thank you, and glad for all the presentations, Patty.
I'm Jackie Pourhan. Sorry, I don't have a camera on today, but I am the membership and conference manager for CFHA. So I just always like to listen in and hear what's going on and answer any questions if you have them.
Great, thank you. Did we miss anyone else, or did we get everyone? Okay. So I heard a couple of things. Resident training. I heard different ways to address specific population, and also general how to train or teach integrated care or collaborative care to providers. So I think I would be covering more of how to train psychiatry providers, different level of different stages in their career. And we are coming up with more of how to train primary care providers, also the PCPs. So hopefully that's going to be soon next presentation. All right, let me get started. And please feel free to stop me and we can chat if there's a specific question about anything. I'm going to make sure I open the right one. Okay. The window you said it. Okay, sorry. Okay. All right. So teaching integrated care to diverse psychiatry learners, and I've been part of a few programs which I'll talk about. So I'll start with residency training. We have exposure to integrated care models, specifically collaborative care models in all years of residency. So this is like a summary chart of what exposures they have. For PGY-1s, we have this pathway meetings where they get to learn what's happening at UW, but more detailed training starting from PGY-2 when they're in psychiatry rotations. And I'll talk about each of these rotations, what we have. So let me start with integrated care pathway. So these are actually, the goal for this is to have a space or place where all residents can come in, join in, learn about integrated care, meet different faculty doing this work at UW and also nationally. So sometimes we invite.
Raman, are you advancing your slides? I wonder if they've frozen.
Oh, it's not going this, okay. I am, but they're not showing in your screen?
No.
All right, so probably we'll have to, let me stop and try.
I'm worried about this being an issue.
I've had this before. Okay, let me try again once, and if it doesn't go, then I'll request you.
Okay.
Can you see now?
I can just see your main, and then it's on the one where you can see the ones on the left, and then you can see the one. So do you want to try to advance?
I am
You
actually.
want to put on?
Let's do it then. Dr. Gibson, if you can do it for me, please.
Sure.
Just to avoid wasting time. All right. Okay.
Okay.
Thank you, Dr. Gibson. The next one, and I can go to the next one. So this, I don't know if everybody was able to see that one, the table. Okay, so this was the general kind of summary of the exposure to integrated care training for different years of residency. So as I had mentioned, PGY-1 just get to attend those meetings so that they are in touch of what's happening. And PGY-2 onwards, we have more of rotations and teaching more details about integrated care, specifically collaborative care model. Next slide, Dr. Gibson. So the goal, I'm going to start with the integrated care pathway, what that is and what's the goal. The idea was to have a place where all residents can come, meet, learn about integrated care projects happening, what it is, and meet different faculty doing this work at UW and nationally. So this is usually how we do this is we have brief presentation and leave a lot of time for discussion. Next slide, please. So these meetings are usually lunchtime meetings. It's every other month. And there's a faculty lead, that's me. And also we have a resident lead who applies to be part of this. And we figure out topics which are of interest and who's doing what. And that's how we decide on topics and presentations for the meetings. We send a newsletter in advance so that they know the details of what the presentation is going to be, and also about other updates, what's happening in this integrated care world in our university. We have a huge department, so sometimes it's very hard to keep up with what's going on, and also kind of updating people about the latest projects. So we've recently started created a website where we have the past topics, the guest speakers whom we had, and also resources they had recommended based on their topic. So to give you an example, Dr. Ratzlev and Dr. Nutzer came to talk about how to advocate for integrated care at larger scale, what their role has been, where we are at with this. And the another topic we had was Dr. Bud Bhavana, who talked about his experience doing integrated care in specific population in Lummi Tribal Health Center, and what are the limitations, pros and cons, and how do you modify collaborative care model in different populations, specifically the one he's working with. Next slide, please. So that was a pathway meetings where most of the residents come, and we also send the newsletter to faculty. So if some faculty is interested to know about specific thing we are covering, they also join us. So then we start training from PGY-2. So this new rotation, well, not so new anymore. This was started 2 years ago. We felt the need of introducing more in-depth training for integrated care earlier in the career, so that people, before we just had it in 4th year, and that time most of the people had made up their mind what they wanted to do. So this was a great way of introducing earlier in their career in case somebody wants to follow this path. And also the other main reason was to introduce residents to concept of population-based care, different models which exist, of course, including the collaborative care model, co-located, and the traditional consultation model, and also learn basics about implementation. What are the steps involved when we want to implement collaborative care model in a clinic? So this is a very introductory and observation kind of a training where they get to read a lot and more of observe how this work happens and see if they're interested. Next slide, please. So this is a 3-week rotation. 1 week is usually, that's when they can take vacation time. But I've had residents who did it for 4 weeks. So it's the way I've created this rotation with Dr. Ratzlaff is we're able to be very flexible about this rotation. It's a 3-week with each week designated to specific topics. So starting with basics about integrated care, collaborative care. Then week 2, we talk about telepsychiatry. And that you can imagine we've modified quite a bit because now everybody's way more familiar with telepsychiatry. And week 3 is they get to meet with AIMS staff and learn about what happens there and what is implementation and what are the steps involved. Next slide, please. So this is an example of how the online kind of course looks like for them. So this is the week 1. So they have set of readings they have to complete and clinical observation, which I'm expecting them to complete, at least to like BHIP clinic is where the collaborative care model is in primary care. And the third is ICT, like different didactics. We have different experiences they can get in integrated care. So I've created this rotation. The other nice thing about this rotation is we call it a passport style rotation. So less faculty time. So residents have to create their own schedule, which they enjoy. And that way different learner groups also can adjust according to what their preference is. So they not only learn about integrated care, but also learn about how to manage a schedule and also be responsible for their completion. Mentor, I usually cover the first week, or Dr. Whitfield does, and we check in the beginning, give them orientation, give them basics about integrated care, expect them to go through these readings, and then meet again end of the week, discuss about what they read, what they learned, and also if they covered all these requirements for that week. So they have a tracking sheet which they sign and write themselves when they completed those. So it's a pretty neat rotation, and people so far have given very good feedback. Next slide, please. So this is a sample of schedule, how it looks like, meeting with mentor, reading and attending clinics. So just to give you a sense of how their day looks like. So there's a lot of flexibility, room for flexibility, a lot of room for learning. And also I encourage if they have interest in specific population like perinatal or child and adolescent, so I connect them with those attendings as well to learn more about that population, how it's done. Like perinatal, we have had few residents interested in that. So we have Dr. Bhatt who's doing a lot of work in collaborative care models in perinatal population. Next slide, please. So in 3 and 4 year, we have didactics and clinical rotation. Goal is to have next level of knowledge about population health and these models, learn about the evidence, and also, BHIP, Behavioral Health Integration Program, which is basically collaborative care model in primary care. So we call those clinics like BHIP clinics. So I don't know if that answered your question. Please let me know if it wasn't clear. So the didactic and clinical rotations, more in-depth training. Next slide, please. So I'm starting a new this year didactic for 3rd year because I felt there was a gap in the 3rd year. We didn't have didactics before. So this year we try to do it earlier in the year because residents start their rotation from July so that they know what they are doing. Our topics covered are like, what are the limitations of access in mental health? What are the pros and cons about different models which have been existing for years? And more details about collaborative care model evidence, what is the team members and their roles. Pretty similar to that APA training, but much shorter version of it. And also giving them a sense of what is registry and how do you review cases. More in-depth, but still on an introductory level so that they are ready for the clinical rotation. Next slide, please. So I'll talk about the rotation after this. So didactic for 4th year, again, earlier in the year is the preference. I have it in 2 weeks for 4th year residents. So this year onwards, we'll cover more advanced system-based topics for these residents. So differential is as the title we use, but it's more of learning how, when there's a problem in the system, how do you look at broader system, where and how you can modify. And we gave examples of thinking about systems instead of just focusing on the patient in front of you. So a little more advanced topics than the basic collaborative care topics. So learning more about billing, finances, about these models, learning more about implementation. So this is a long 4-hour didactic with them. And so we will cover these advanced topics. Next slide, please. The clinical rotation for both 3rd and 4th year is usually 6 months, once a week or half day a week. And again, they get to work more in collaborative care model. And in this teaching rotation, we expect attendings to faculty to teach those 6 modules which are available in AIMS website. We need to modify those, but those are the modules we are going with for now. And also relevant articles depending on what cases they are seeing or what questions come up with different residents and attendings. We expect attendings or faculty to supervise at least 30 minutes if it's half day or 60 minutes a week if it's a full day for a resident in those rotation. Next slide, please. So this is an example we give to both residents and attendings to have a sense of how the progression should look in that rotation. Because before we all faculty were doing different. Sometimes some faculty were expecting the residents to start as soon as they started the rotation, and some were taking too long to let them be more independent. So this is kind of a general sense, like shadowing, observing the attending for direct consultation, because in our collaborative care model, we have 4 hours of direct consultation, 1.5 hours of case review meetings. So in this direct consultations side, so we're expecting residents to shadow for 1 to 2 months. If it's a 3rd year, maybe longer. If it's a 4th year, less. So middle of rotation, they start seeing a couple of patients with supervision, and then end of the rotation, rest faculty just joins for last 10 minutes so that they could bill for that visit. Next slide, please. For the systematic case review progression, this is the example. In the beginning, most of the residents need more time to shadow because this is a very new concept for them. Kind of getting information from care manager and giving recommendations based on that. So again, middle of the rotation, giving them 1 or 2 cases, and by the end of it, we are hoping the residents can run the systematic caseload review. So this is just an example, and every attending is flexible depending on the trainee's experience and interest. Next slide, please. So other psychiatry resident elective rotations we started from last year. So these are the basic collaborative care rotations. The other rotations we started, next slide, please. So we have this implementation rotation, which we used to have just for the fellows. So we modified the same one, but offered it to residents now. So it's a non-clinical one, focuses on different process and steps involved in implementation. It's again 6 to 12 months, half day a week. Initially, the focus is just didactics. So a lot of articles, reviewing articles and teaching. And then later on, they get involved in whatever implementation project is going at AIMS Center, and they're more listening into those calls, but also expect to kind of learn from it and be part of the discussion later on after the call. Next slide, please. So this is an example. They started last year, they did twice a month calls from November to June to these 2 implementation sites. And we had 2 residents, so they each took on responsibility for one. They weren't running the calls, but they were more observing and more responsible if something had to be looked up or discussion after the calls. Next slide, please. The second elective rotation, new rotation we started last year is Lummi Tribal Health Center rotation. This is to get more exposure to different population and how integrated care works in different settings. Again, it's run by Dr. Wana and Dr. Whitfield, and the goal is to increase resident exposure to working in tribal health centers, 1 day a week, 6 to 12 months. And this didactic component, this clinical component. And again, most of the rotations I've talked about, we expect some kind of project in the end, even if that means more of presentation of what they learned during that rotation. So that's our sense of evaluation, how they participate in what they learned. Next slide, please. So future plans for residency training. I'm hoping to engage more residents in the pathway meetings. and continue to improve the, sorry, my son is home, I'm so sorry. Continue to improve the quality of training and also having more clinical rotations. We want to give, I'm reviewing more of also these co-located rotations which we have. So see if that's a way we can give exposure to them to both co-located and collaborative care so that they can get a sense of comparing. They all do those co-located, but I want to see how we can combine them and expose them to learn how to compare and what's pros and cons of these rotations. Next slide, please. So now for fellowships, I want to make sure time-wise we are good. Next slide, please. So we have integrated care training program, which is full-time fellowship, which I'm running and working on. Next slide, please. So it's a 1-year non-ACGME fellowship. And the focus in this fellowship is developing clinical and system-based skills to deliver population mental health care. I think system-based skills is where, at least in my training, and I see in our training here, is somewhere we lack that exposure to residents. So our goal and hope is they get more and more exposure to that during this fellowship. So broadly, fellows get clinical experience, implementation experience, more hands-on experience doing the implementation process, learn about QI, which is an important component of integrated care training, specifically collaborative care, and then leadership skills. Next slide, please. So rotations, they have rotations in this fellowship include collaborative care rotation in primary care, which I had in the past called as BHIP, BHIP. So collaborative care rotation in our primary care clinics in the university. So telepsychiatry experience, and this includes clinical seeing patients, as well as being part of these different consultation programs we have for the providers in Washington state. Then learning about brief behavioral skills, which we use in collaborative care implementation, more in-depth training and learning about that. QI, research didactic, combined didactics with CBF is community-based fellowship, which I will talk about later. Next slide, please. So in the QI, quality improvement part of this fellowship, they have to complete a patient safety and quality certificate training in the beginning, and then work on a project with a mentor throughout the year, and should complete it by end of the fellowship. Next slide, please. So clinical experience, collaborative care, as I had mentioned, in our neighborhood clinics, which is primary care clinics. So they not only see patients directly and do case reviews, but also practice these brief behavioral interventions. We expect fellows to have at least 1 or 2 patients to practice or do brief behavioral interventions like CBT, PST, MI. So they get training for that, but we also make them go through that so that they can teach the social worker or care manager who's working with us. Co-located model, this is a new rotation I'm hoping to add from next year, where they get to work in a co-located model, because I've realized once fellows graduate, very rarely somebody does collaborative care for full time. So it's usually part of it, and part of it it's co-located or long-term clinics. So we were thinking we should add this co-located clinic as well, where they get to do consultations or maybe have patients for a little bit longer. And last, telepsychiatry, as I mentioned, clinical work. Also those phone consultation programs we have. So we have one for perinatal, Alpha Mom for perinatal population. We have for general psychiatry, PCL, we call it, psychiatry consultation line, where any provider from Washington state can call. And also we have one phone consultation line for child and adolescent population. And in that also they meet with Dr. Erickson during the telepsychiatry literature. Next slide, please. So those were the rotations. We have combined didactics. What I mean by combined is because they're diverse kind of trainees who are part of this didactics. We are including more trainees in this from this year. And we have around 26 sessions starting this year. Before we had more. The emphasis again on the clinical skills and system-based skills. So clinical skills needed in collaborative care. So overall, we've got very good feedback and high scores on the quality of those didactics. And why we're calling it combined is because the participants in these didactics are those integrated care training fellows, full-time fellows, which I'm talking about. So community-based fellowship, I'll talk about soon. And then CL fellows, Jerry psychiatry fellows, perinatal fellows, and also sometimes psychology residents. At times we have PGY-4 and 2 also join these didactics. So it's really nice to see all the diverse kind of learners part of it, and it's to see them having a discussion about different topics. Next slide, please. So for other subspecialty fellowships, the trainings we have, next slide, please. So one of the subspecialty CL fellows have been very constantly part of our training for the fellowship. So goal again is to give them more in-depth experience in integrated care. In fact, our CL fellowship director kind of always says that this is one of the attraction for a lot of fellows who come here. So far, we have fellows who are for last year or two who've been joining us is Jerry, CL, perinatal. And again, the experience they get is clinical rotation for 3 months, and they are also part of these combined didactics throughout the year. Next slide, please. So let's talk about this community-based fellowship, CBF, which I've mentioned a few times in the past. So the goal for this fellowship is actually, we felt there was a need to have some fellowship for the practicing providers, psychiatric practicing providers. So this fellowship is, I think we are in our 3rd year or 4th year, starting from September. We've had different practicing psychiatric providers, MDs, DOs, ARNPs, and nurse practitioners part of this fellowship. So far, we've offered it in our Washington state. And I think this year we have an applicant out of state. It's modeled after that MBA program. So it's 10 months, mostly remote and online. We are expecting or asking the providers who apply for it to have at least 0.1 FTE, a time commitments of 4 hours a week. Every year we've had around 12 to 15 fellows and who've completed this fellowship. Next slide, please. So the components of this fellowship include online didactics, which is throughout the year, and then quarterly in-person meetings. And that's a great time for them to meet each other and also meet the faculty in person. So monthly mentorship and also quality improvement project, which they have to complete for this fellowship. And you can imagine, because of COVID, the quarterly in-person meetings have been mostly on Zoom. Next slide, please. We can go to the next slide. For the online didactics, it's approximately, we're hoping for each topic to be around 3 hours of work per topic. Mostly the learning is asynchronous learning, so that the providers have flexibility, because everybody's work, we all know, is very busy. It's hard to take a chunk of time to meet someone. So most of the learning is asynchronous. We will have asynchronous sessions starting September, but that is optional for community-based fellows. They're not required to attend, but the full-time fellows, CL, Jerry fellows, and ICTP fellows are required to attend those. The content of this online didactics usually include recorded presentations by faculty, selected readings for that specific topic, and also activities for that topic to evaluate if they're able to understand the content. And last but not the least, all topics have some kind of discussion questions which they have to type on the discussion board. And of course, the evaluations to see what we can improve. So to give you a sense of how the didactic page looks like for community-based fellows, but soon we're going to have all fellows to be kind of doing the same didactic. So activities, this is Dr. Raslev's topic, patient and family engagement. So she has a video for 5 minutes, number one. Number two, she has 19-minute video that she wants people to see. And then the third activity for them is to pick one article, think of one of their patients, and review that article. And number 4 is that they have to write a paragraph in response to discussion describing the case the fellow thought of related to the article. So this way they have flexible. So it's usually they have time of week and a half when they can complete this. But we expect them to do stepwise so that the learning is appropriate. So 1, 2, step 3, and then 4 discussion board. And for the discussion board is when faculty replies back. So that's the kind of general how these online didactics look. But for our full-time fellows, we will have, instead of that discussion board, we will have that synchronous session for 1 hour where they can have that discussion with the faculty live. Next slide, please. So examples of topics, clinical topics, and it's split between clinical and system-based. So clinical topics, we start with overview of assessment and treatment in collaborative care model, how it is different, how is mood disorders treated in primary care under the collaborative care model, like how do you educate a care manager, how do you educate primary care, how do you educate patients, and similarly for substance use disorder. We do cover what is the evidence-based treatment, which is like basic knowledge for most of the fellows, but we still cover that because evidence-based is one of the principles. But most of the didactic is more focused on that disorder in collaborative care models. We're not teaching how do you treat depression. We talk about evidence-based treatment, but focus is in collaborative care. How would you give recommendation? What's the best way to do it? What is appropriate with this information? And system-based topics like introduction to telepsychiatry, collaborative care team culture, how do you evaluate that? How do you work with that? And leadership liability are some of the examples. Next slide, please. So that's online didactics. So then we have these quarterly in-person sessions, which are 2-day meetings, and they usually cover clinical consultation skills and evidence-based treatment. And also they usually have some social activity for fellows and faculty on Monday so that they can meet each other and get to know each other. Next slide, please. Topics, we have a very clear structure for these in-person sessions, which are for 2 days. So short-term psychotherapy, one of them is covered during these in-person sessions. Then QI topic is covered. Mentorship topic is covered, leadership topic is covered, psychopharmacology. I think they've created a curriculum where they start with depression, anxiety, and then they go on about how to treat in collaborative care, more like clinical cases, and asking people to do case review notes and kind of think about their recommendations. So again, the goal is not to teach them how to treat depression, anxiety. All these fellows know that, but more of in collaborative care model. How do you give recommendations? What is appropriate? What is not? Next slide, please. And the third section is a QI section. So they'll get to learn about QI methods, apply QI methods to address a quality issue in fellows' own setting, whatever they're doing in the outpatient clinic or they work in primary care, and gain experience applying integrated care principles, which we all probably know. Next slide, please. And the next section, so going back to the QI, those are monthly meetings with the group of fellows, I think there are 3 or 4 in each group, and one QI mentor, one QI faculty is assigned. So they meet with the fellows once a month to talk about one of the methods or topics and also talk about their projects and support them throughout the fellowship. Next slide, please. So the last section, mentorship. So online didactics, in-person sessions, QI, and mentorship. So this is more to develop a personal mentoring relationship to support the individual integrated care goals of each fellow and maintain engagement with all parts of the fellowship. So mentors are people, go to people, like if I see online didactics, somebody's not responding. So I usually reach out to the mentor to discuss how we can support the fellow. So mentors, next slide, please. So mentors usually meet one-to-one. They have one faculty member assigned to each fellows. And I think one faculty has, again, 3 to 4 fellows working with them. And monthly hour-long meetings occur via video conference, where they discuss about how the fellowship is going, what's going on. If things are going smoothly, then they usually, mentors have clinical cases where they discuss how they would give recommendations, how they would approach in collaborative care model. Next slide, please. We can go next slide. So psychiatry council. So this was our residency training, all the different fellowships we have and their experience or training at UW. So we got this feedback from a lot of graduates that they wanted to be in touch, and how can they keep in touch and see what's going on. So last year, Dr. Chang, Denise Chang, has started this psychiatry consultant learning collaborative. So the goal for this was ongoing connection with people who have graduated, or also people who have not been part of our training, just to get to meet with a group of people who are doing integrated care, and also get this additional support for the, as I said, graduate training, provide ongoing integrated care education, fostering learning and support network, support sustainment of integrated care, which is a big step after you've started sustaining is also very important. So this is a great space where people get together and talk and discuss about all of these topics. So this started last year. So far, it's been a good success. Next slide, please. So a little bit about this. It's again a monthly lunch hour meeting. It's 4th of Tuesday. Usually it starts with some kind of didactic topic, 15 to 20 minutes. We want to keep a lot of time for discussion. So usually spend less time on these slides. And topics repeat every 6 months. It's still first year kind of, I think Dr. Chang is trying to get a sense of what is most useful for the people who are joining this meeting. Next slide, please. So these are the upcoming schedule or topics, which for this meeting, so working with behavioral health care managers. Again, these are very casual meetings, so a little bit of presentation, but mostly discussion about different people's experience. So not only UW faculty, but also a lot of people are doing amazing work in integrated care. So it's a great time for us to, I've attended a few of them. It's really nice to hear what people are doing and kind of learn from their experiences. So this is an example. Next slide. So we've been doing, so ICTP, Integrated Care Training Program, started on 6 years ago. And so far we've had 48 fellows graduated from our program, more than 100 residents who graduated and got experience in integrated care. And of course, the 38 community-based psychiatry fellows, that CBF fellowship I talked about, who've graduated from our program. So feel very good about the training and how many people have learned, but we're always looking for how to improve this more further and have more specific education for different sets of providers or different specialties. Next slide, please. So this is our website, ictp.uw.edu, for if you want to look up more details about our different programs we have. And also, please feel free to email us at this. So if you have a specific question about specific training, this is a good general email, and our staff are very good in forwarding to the person who would be appropriate for that question. And I forgot to add my email. And of course, please feel free to email me. My email is my letter of my first name, Toor, my last name, TOOR, at uw.edu. So please feel free to email me if any questions or thoughts or any ideas. Thank you, Dr. Gibson. That's all I have. Questions, thoughts, anything I can talk more about, any specific program? I tried to put very basic information because it's very tempting to get lost. I want to tell you what we cover, but I'm like, people might not be that interested, but I'm happy to share with any specific program which was more of interest.
Thank you, Raman. That's very interesting. And I appreciate that you've given us a good overview as well as some details. And we'll be sharing this recording on the website. And if there are slides that you want us to share with the group, we can also do that.
Oh, I'm happy to send my slides, Dr. Gibson. You have them, but I'm happy to send them in PDF or whatever is convenient.
Okay. Well, what other questions or comments does anyone have? We'll just open the floor there.
Yeah, thank you very much for that excellent presentation and all the work on collaborative care. I'm just curious if you're aware of other academic programs around the country that might be doing something similar. I know UW is very much ahead of the rest of the field, but are others catching up?
I don't know personally. I did have a meeting where group of us, the APA listserv, where collaborative care listserv, where people had interest to talk about this. So I did that meeting a few months ago. I don't remember specific programs, but I know I'm aware that they have programs doing as good, if not better. Of course, I know about UW because I'm part of most of these programs. But to answer your question, yes, there are programs. I don't remember the specific names and which program, but I'm happy to go back to my email and check and give you a kind of let you know which programs I heard from that time. Would that be helpful, Mary?
Thank you. No, I was just interested more in a ballpark kind of a number. And and thinking about the two programs, the two academic programs that I'm involved with, Northwestern University and UIC. I believe Northwestern has something, but I haven't thought to look into specifically whether they have a structure similar to yours. So no, I was just curious if like kind of what we can expect in terms of developing training at our local residency programs.
Sure. I definitely know the clinical rotations for most of the people because a lot of people are practicing collaborative care and they have residents working with them. I'm not aware of, I personally am not aware of the fellowships or detailed kind of rotations or more of learning about that, like PGY-2 rotation. So that I'm not aware of, but I know clinical rotations, I heard from a lot of people talking about the billing component of it. And I should have remembered. Sorry, totally blanking.
It's Lori Rainey. One thing that is available, if you have sites that are or academic institutions that are interested, AdPERT they've developed the modules that you guys probably use at UW, but they've developed modules for residency training that are available for free. So that is out there if you know of institutions that aren't quite sure how to get started or have some knowledge but want a formal curriculum for residents. I think it's 6 modules, and it is available for residency training. It might even be on the AIMS website, the actual modules for residents.
Yes, thank you, Dr. Rennie. Yeah, those are the modules I mentioned in the clinical rotations we go over. So I modified them a few years ago. So one of the projects is to update them, but we have those modules available on AIMS website. Those are great modules to get an overall detailed sense of collaborative care. Thank you for reminding me that, Dr. Rennie. I'm also happy to share with what we are doing over here, if that helps with the kind of curriculum. I'm happy to share what we are doing here. I think PGY 3 and 4, it's mostly those 6 modules and the additional didactic. And PGY 2 is, I'm happy to tell you share with what our curriculum is for that.
I'm sorry, I don't mean to dominate, but my other question was about whole health training involving residents or fellows in things to do with complementary and alternative medicine. Do you consider that part of the integrated and collaborative care teaching model, or would you deal with that separately?
That's a great question. We have a VA faculty, Dr. Kopes, who teaches, who actually nationally teaches about whole health. He does didactic for our fellows, both full-time fellows and community-based fellows. It's like 1 day long didactic, that one in-person session. So it's part of integrated care fellowship training in that they learn about it, but nothing more than that. Dr. Kopes is the one who teaches that. That's a great question and thought. So we don't have anything more than that. The whole session and exposure, and people who are interested to connect with him and talk about it.
Thank you.
It's certainly a great idea, right? Because when you're doing the case review and talking to the care manager, having some knowledge of, you know, what else might be available out there, especially if you've got a chronic pain patient and their PHQ-9 score is not changing very much, you know, just to have some thoughts and knowledge around that, I think would be very helpful. That's again, a great question and something for the psychiatric consultants to be thinking about in terms of when they're doing the registry review. I just tried dry needling for the first time. I'm not quite sure about it, but, you know, just thinking about something alternative I could do for my hip pain.
I agree, Dr. Rainey. I think that's a good, we just have didactic on it, but I think I want to think more about it and talk to Dr. Ratzliff about it, what we can do to improve people's experience.
I have two questions. One is, do we know if the psychiatric boards have any competency questions now that have to do with integrated care or collaborative care management? Is that part of expected training for all residents yet?
That's actually a great question. That's something I would have to check with Dr. Ratzler. I'm not aware of it because I'm hoping this integrated care training is more of a standard training for most of the residents. Even the rotations I talked about today, all of them are elective rotations. So people who are interested do it, not everybody, except the didactics everybody gets. So I'm not aware of it, but that's a good question. I will talk to Dr. Raslip and definitely get back to you on that.
Mm-hmm. And any of y'all may know this. I know with CFHA, we're trying to create a community of psychiatrists and anyone else interested in integrated care. And Raman, you've talked about learning collaborative of people trying to come together. And I know the APA has the integrated care segment on the website. Are there any other formal or semi-formal organizations of psychiatrists to connect who are doing integrated care?
So here, Dr. Gibson, here at UW, that's the new meetings we started. So that's the one I know, which we started from last year. Everybody's welcome to join. And more people the better because we get to learn from each other. So those are the new ones we know at UW we started. And of course, those AIMS calls, we have monthly calls for the billing and the implementation calls. Other than that, I'm not aware, at least not here at UW.
There is a Facebook group doing it. Eve Fields, I think, started it. She's in South Carolina. So I know there's a Facebook group that meets monthly. They call it coffee hour or something on once a month on Fridays. I mean, again, they're doing the same thing. It's about collaborative care and psychiatrists that are working in that. I just joined it recently, so that, you know, I know that exists. But it sounds like UW is starting a new one.
Yes, Dr. Rainey's the psychiatric consultation meetings once a month for the graduates from our programs and also anybody doing integrated care. We have those meetings on Tuesdays.
Are you guys advertising that or letting people know? I haven't seen it on the APA. How are you guys getting that information out? Is it on the AIMS website so you could register?
It's very new meetings. We just started last year because we got a lot of those questions. How can we continue to stay connected with the programs? So we started new. I know it's on ICTP website. I think link is on my slides where you can find out details, but I'm happy to send the email or of how to kind of sign up for that to Dr. Gibson and she can share. I'm happy to do that. I'm taking notes.
Thank you so much. I appreciate that.
I'll share that. I actually joined it last month for the very first time. I was going back through the website, and the topic was sustainability and financial issues related to sustainability. And where I'm working now, I'm needing to answer those questions to leadership. And so it was really helpful. Anna and is it Denise Chang?
He's the one who runs us, yes.
So it was really good as far as just me and I think we had about 8 or 10 people on the call, but it was like a lot like this type of meeting where there's people coming together with similar questions. And it's nice because you feel like the people who are answering them have the evidence base to share or to be able to find information for you. So I guess we need to get the word out for you all.
Yes, this is my one way of getting the word out from this meeting. And they also the APA list of people who've done that collaborative care training through the APA. So we also get nice questions on that list about billing, about residency training. That's how we ended up scheduling one of those meetings where people who are having residents learn collaborative care, what different people are doing. So that's another group where I've heard a lot of good questions about collaborative care.
Okay.
Yeah.
Do you know if that listserv is something that we could also advertise? Because we could put on our CFHA page these different links and for psychiatrists or other folks to go to.
Dr. Gibson, I know Dr. Kern is usually the one who runs it or gets back to people who have questions. I don't know if Dr. Rainey, you're also part of that, because it's people who've done that APA training. They get they sign up, but I'm sure anybody can sign up and ask questions on that.
Yeah, I'm not a part of that. I was one of the trainers for it, so I don't know because we didn't sign up if we're not part of that. But it's more of there's a lot of pushing information out, right? Or do you see a lot of questions on it too?
I've seen more of questions, people sharing the ADHD protocol they're using. The billing questions came up. Recently, somebody asked about the training question, residency training, care manager training. So it's kind of place where people ask a question, anybody knows, anybody resource, or anybody can help us with that. So I found
who's answering the questions? Can you tell?
What's
John
that?
Kern, she said John Kern or
Kern, yeah, he's the one who usually kind of gets back, but it's also anybody on the listserv. Like I've kind of talked about the residency training we have, somebody talked about the ADHD protocol they have. So, but Dr. Kern is the one who's the main person, but anybody in that can email.
Are the APA trainings completed now? Or are there any ongoing?
They're completed. They've been completed for about a year.
It's been nice to see how the APA websites continues to get updated and the resource, especially around billing and Medicaid, all that work y'all did on the Medicaid billing.
Yeah, I don't think they've updated anything in a while.
Okay.
They added those consultation codes, billing separately for consultation.
Yeah. And
they have a handout and a patient handout, but I think that's the latest update on that site.
Who would be in charge of that section, that integrated care section?
Becky Yowell and Kristen Kroger.
Yeah, I think Anna Ratzlaff works quite a bit with them. So I know she has had a lot of editing and adding when she has time, doing 100 things.
Well, I see that we could probably keep talking for a while, but thank you so much for your time today, Raman, and also Lori and everybody that was able to log on. There were a few chats where people said goodbye and thank you. So thanks, Raman. And
thank you so much.
Post the recording and the PowerPoint and any other websites or links that you want me to put on the site and then share with the mailing list.
Absolutely. I'm happy to do that. And thank you for having me. It was great fun.
Thank you very much.
Bye, Dr. Gibson.